Now we have the pleasure of moving on to our own Dr. Bradley Carthon, who's an associate professor in the Department of Hematology, Medical Oncology here at Emory University, and also our section chief of Hematology and Oncology for Emory University Hospital Midtown. Dr. Carthon works with the Genitourinary Oncology team at Winship in order to discover novel therapeutic targets and lead clinical trials that utilize novel treatment combinations for our patients with prostate, bladder, renal, and other genitourinary malignancies. So today, Dr. Carthon will be presenting on patient participation in clinical research, lessons from prostate and genitourinary cancer trials. Brad, I'll turn it over to you.
Thank you. That's a tough act to follow. Dr. Brawley is indeed one of the giants of cancer care and epidemiology. But I will do my best to talk to you a little bit today about clinical research with regards to genitourinary cancer patients, and more specifically, prostate cancer patients. There are a lot of lessons that have come to light over the last few years that really help to pose some interesting questions and interesting answers for our patients. So we know that cancer, prostate cancer, is the #1 leading cause of cancer, type of cancer in men in the United States. There's 192,000 cases predicted to take place in 2020 and about 33,000 deaths. Much of the tide of prostate cancer diagnoses has taken place in the context of changes with our screening recommendations. In the 1990s, PSA was introduced as a testing modality and as a tumor marker. There was a spike in diagnoses at the time, but as more and more people were screened, as Dr. Brawley mentioned, several patients had side effects or bad outcomes with a disease that was not going to threaten their life. And so in 2012, there was a reversal to the recommendation on screening, such that there was no recommendation for full and system-wide screening, but only in high-risk groups. This was visited and then revisited back in 2017, where the discussion between patient and doctor with risk and benefit was recommended. Now, the problem with this was that none of these changes applied to high-risk populations, patients with family history, African-American patients. However, there was confusion and drops in screening rates, as we'll see in a little bit. Over time, if we look at the percentages of screening among African-American and non-African-American men between 2007 and 2014, we can see that those rates indeed dropped specifically around the time of the second modification, around the time of the screening modification. But the important thing is that at every step along the way, African-Americans underwent screening at a lower rate than their counterparts. And what did this do? This led to a change in the presentation. So immediately after those screening revisions, there was a change in the incidence of all prostate cancer. However, there was a slight increase in metastases identified as patients presented with later disease. Now, we can't correlate directly the changes in screening and survival, but we can see that in patients that had less rates of screening, they also have lower 5-year survival at including all stages. This would include 96% for African Americans at 5 years versus 98% among all races and among white patients individually. And if we step back and look at timeframes before the screening recommendation changes and then after the screening recommendation changes, we can see that afterwards there was abrogation of a survival disparity that existed pre-PSA screening and then post-PSA screening recommendation changes. And so it's quite likely that emphasis on discussion in those highest risk patients could lead to decrease in those survival disparities. But it's not just screening. We know that African-American patients have lower rates of screening, but what about actual intervention and treatment modalities for localized disease? Well, when it comes to prostatectomy, we know that African-American or Black patients have lower rates of radical prostatectomy as their primary treatment. And this is over years from 1992 to 2009. This was identified in JAMA Oncology by examining 26,000 men to determine and follow this trend. Moreover, if patients are referred for radiation, not surgery or watchful waiting, but actual intervention by radiation, studies have looked at patients and the number of those patients that meet systematic thresholds for quality care. For example, in this study of 600 patients, about 450 white and about 125 Black patients, they were able to see that in men who had dose escalated radiation, there was a difference in the rates of receipt of that measure. There was a difference in the image-guided approach to radiotherapy, and there were differences in inclusion of lymph node areas for those patients that do need that treatment. And so not only do we have screening and surgical, but also radiation disparities. We know, as Dr. Bradley mentioned, that trial participation ensures high quality care. But we know that this is also something that's a problem. If we look at approximately 87,000 people, I think it's 87,000 people, about 3% of those were African-American when we talk about pharmaceutical sponsored trials. About 9% of the patients in SWOG sponsored trials were African-American compared to 12% of the cancer population. And when you look at prostate cancer specific trials, about 3% of those patients are participants in pharmaceutical sponsored studies, about 12% in SWOG cooperative group sponsored studies, but that's compared to 15% of all cancer patients that are African-American. So once again, lower rates than exist in the general population. And this is not just the United States. This group looked at 894,000 patients with 72 global phase 3 and 4 trials dealing with prostate cancer treatment, screening, and prevention. And of those trials, white men made up 96% of the study population. And so the diversity of the worldwide population was not adequately represented. In trying to determine some of the hurdles, indeed, some of these are socioeconomic, and we'll talk a little bit about that, but there are also some deep-seated trust and other issues that exist in African-American patients. Focus groups are done in many different instances, and this is one in where focus groups were set up in several states through organizations such as 100 Black Men of America, word of mouth through community groups, and they asked the participants, what are some of the barriers, not only for clinical trials, but also genomic testing? And things that came up included healthcare system mistrust, reluctance to seek medical care, lack of understanding of the terminology or prostate cancer, and misinformation about the usage of PSA. So all of these are hurdles that have been demonstrated in multiple different studies and multiple different publications that we need to keep in mind as we're talking to our patients about clinical trials and other things that can enhance care, such as genomic screening, which is recommended through NCCN guidelines currently for all metastatic prostate cancer patients. But as mentioned by several of the speakers prior, we do know that when patients have access, some of the things that we think of as disparities can dissipate. And this includes treatment with various modalities. We'll look at each of these. For example, Docetaxel is commonly used in prostate cancer for many different states of the disease, either in the upfront setting or when men develop castration-resistant prostate cancer. The problem is that out of 9 trials that looked at these agents or this agent, anywhere from 3% to 7 or 8% were included. And that makes it really challenging to see how those patients do. The numbers aren't large enough. Dr. Susan Hallaby, worked with meta-analysis to try and pull that information out to see if there's some innate difference in patients who self-identified as African-American or Black. And so out of these trials, 9 were available for phase 3 usage, and that included about 9,000 African-American patients. And what we saw, and what we can see here, and this was published in JCO last year and was an abstract, late-breaking abstract presentation at ASCO, was that there was a very similar outcomes between white and Black patients, and in some instances, even thought to be enhanced. But what about other agents? Chemotherapy is one approach, But we now have targeted therapy that utilizes the androgen pathway, which we know is very active in prostate cancer and particularly in African American patients. The Abiraterone study was one of the first prospective studies to look at abiraterone in African American and then white men with castration-resistant prostate cancer. 50 white men, 50 black men were given abiraterone and prednisone and followed for radiographic PFS and PSA reduction. And notably, PFS was enhanced in black patients over white patients, and the PSA declines were deeper and more sustained in black patients over their white counterparts. And that wasn't the only study that looked at that. That was a prospective study, but researchers at Duke University also looked at their patients that had been treated, matched them up for certain clinical characteristics, and found 45 black patients, 90 white case-controlled patients, and assessed how they responded to abiraterone. And we can see by this waterfall plot analysis that black patients and white patients both had profound responses that were very similar in nature. Moreover, the overall survival for these patients, who sometimes had higher levels of PSA, higher levels of ALK-Phos or other sites of distant disease, seemed to do just as well with regards to survival and PSA response and progression-free survival. But it continues. Sipuleucel-T is an autologous dendritic vaccine therapy. It's utilized in men with castration-resistant prostate cancer who have very minimal symptomatic or asymptomatic disease. It was approved based on an overall survival benefit among all men. But Dr. Sartor looked at this and pulled out similar patients with PSA values that were very much the same. And he stratified Caucasian and African American patients and saw a 30% reduction in overall mortality in African American patients that received this therapy. Now, the reasons for this are not quite known, but once again, patients that can often have higher levels of PSA or higher levels of presenting adverse characteristics can do very well in controlled environments such as clinical trials or equal access treatment centers. And then lastly, what about radiopharmaceuticals? This is a very unique treatment that utilizes a calcimimetic with attached radioactive pharmaceutical particles. And this also led to an overall survival benefit. It's an approved agent in NCCN guidelines. And in looking at these patients, there was no notable difference at first glance, but upon multivariable analysis, it was shown that with all characteristics taken into account, Black patients had a 25% mortality benefit compared to their white counterparts, and this was statistically significant. So we know that in those trials, patients can have very similar outcomes in those controlled environments, but our life is not such like that, especially in Metro Atlanta, where in Vinings, the life expectancy of 87.6 years is, as Dr. Browley mentioned, 20 years more than the life expectancy of residents of DeKalb County, certain parts of DeKalb County. And we know this as well in the nation when we're talking about prostate cancer. If we look around the country at patients who have affluent socioeconomic status and poor socioeconomic status, there can be differences in their outcome. And indeed, we do still see differences in Black outcomes and white outcomes around the country. So we have to think about this not only in local areas, but as a general trend. And as mentioned by several questions in several of the prior breakout sessions, Georgia has a large rural cancer population, and there are disparities that are noted in that instance as well. Many sites of our state have less educational attainment, less income, less employment, and insurance. Moreover, we know through several meta-analyses, and this is just one published in the Oncologist in 2015, that patients that are living further and further away from hospitals where they can receive high quality care often presented with more advanced disease, lower adherence to their recommended treatments, as Dr. Browley mentioned, and worse prognoses. And so we know some of the barriers. We know that there are hospital closures. We're hearing about this in Georgia. Hospital in South Georgia just recently closed. There are financial and mental hardships. There's a shortage of oncology specialists. Patients are having to drive further and go further in order to seek high quality care. And so if the problem is in the community, the solution should also be in the community. And some of these strategies, although may be a bit more difficult to attain than to think about, would be to leverage some of the partnerships that we can set in place. It would be great to have more community health workers and navigators, people to help folks guide and work through some of these challenges. Many patients aren't able to come to Emory because of transportation difficulties. The use of rideshare and other transportation programs might be able to help with that. And so in different parts of the country, different agencies have set up these partnerships. This is one that we recently highlighted in a review done from Dr. Pence and myself, in which a community partnership program in the city of Chicago between Northwestern University and several different agencies, including Chicago City Colleges, the Department of Public Health, the Chicago Public School System, and even other patient advocacy groups set up partnerships in order to do education and then to direct folks to the right and appropriate entities for cancer treatment once they were diagnosed. And in a more local fashion, we actually have a committee that's committed to that. And this was established in April of 2018 to try and develop action plans for outreach. And this has included several different meetings and outreach and speeches and health festivals. Dr. Pence's group has worked with Lamestad Community Health. Our breast colleagues have done much work with the annual breast bowl that takes place here at the Midtown campus. And we've done several different initiatives to make folks aware of the clinical trial opportunities and also screening opportunities and information for the common cancers, including prostate cancer. And we are blessed in that we are in a very diverse environment. And so we have quite a number of patients that are African-American on our clinical trials. High accruals in myeloma and other groups match up with the population that's met here in the Georgia area. However, there is room for improvement and much work that's left to be done. As we look over the years, we see that we do have steady accruals with Blacks and with women participants. Our Hispanic population could likely benefit from the wonderful trials and opportunities that we have here at Winship, and those are some areas that we would like to focus on. And then lastly, many of the bits of data that we've talked about today are retrospective. I think Dr. Brawley mentioned, trying to do subset analysis is really not powered to detect differences in different groups, regardless of whether it's Black or white, or this receptor, that receptor positive. And so there are some prospective trials for African-American men, including the Panther trial, in which 2 agents focused on the androgen receptor pathway are given to patients to see how they're going to do with regards to outcomes with PSA and mortality. This is sponsored up at Duke University, and we actually share some patients on that trial. Moreover, there are other trials looking at the combination of immunotherapy and androgen receptor antagonists in Black gentlemen to see how they respond in markers that can indicate activity along the androgen receptor axis. And then lastly, we have a trial that we're actually about to open here at Emory as well, out of the Moffitt Cancer Center, where adaptive Abiraterone, looking at testosterone levels and PSA levels in African-American and white patients, can help us better determine the dosages that may be necessary for a response. And so in conclusion, we know that prostate cancer remains a leading cause of death. And even though there are disparities, there's progress being made with several new therapeutics. Screening guidelines have helped improve outcomes among those at the highest risk, and that can include those with family history and African-American patients. As we push the envelope for enhanced outcomes, we think back to clinical trials. What are the barriers for that? Many exist, and we're working to try to overcome that through partnerships and community organizational groups that can help with those patients have access. And those efforts not only take place on a national level, but also locally to overcome disparities. But prospective trials are going to be key for all at-risk populations. I'd like to thank the organizers for the time to talk a little bit about some of these interesting topics. And at this point, I'll take any questions.